So the news at the ASH meeting for patients with CLL, we have the results of many phase 3 trials in unfit patients and also in fit patients. And we have the results of the CLL11 trials, which was designed for unfit patients with JR101 plus chlorambucil arm, which is more effective than rituximab plus chlorambucil, and also than chlorambucil used as a single agent. The interest of these results are that many patients have a negative MRD, minimal residual disease, which is a marker of the quality of the response, and a longer duration of response than the patients treated in the R plus chlorambucil arm. So I think it could be the standard now regarding chemotherapy plus immunotherapy in those patients. The second results are in stage A patients, asymptomatic patients who do not need treatment. But we know that in this stage A, 20% of the patients have a high-risk stage A with a quick outcome to a quick evolution to a treatment. So the German group and the French group randomize high-risk patients for receiving early treatment with RFC, or watch and wait. And we have the result of this trial this afternoon, and we show that patients who are treated earlier in the stage A with high-risk stage A have a better outcome and a better progression-free survival than patients who are only in an observational arm. And also the last big phase 3 trial, it's the German trials, which compare the efficacy of R plus bendamustine versus R plus fludarabine plus cyclophosphamide. And the results are not so conclusive because for the R bendamustine arm is less toxic, but the progression-free survival is shorter than in the RFC arm. So the conclusion of this trial is that we have to use RFC in fit patients under 65 years, and we can use R-bendamustine in patients over fit but over 65 years. So I think that are the main results of big phase 3 trials in the ASH meeting. Many results also are shown in this meeting regarding chemo-free treatments with the combination of new compounds, target compounds such as BTK inhibitors, PI3 kinase inhibitors, or BCL2 inhibitors, in combination with monoclonal antibodies such as rituximab. So I think that in the future, we are going to move with a new paradigm in patients using new compounds, and perhaps some patients can be treated without any chemotherapy. But we have to do the proof of concept. It's too early now to say that everybody has to be treated without chemotherapy, because we have many data and good results with RFC, for example, in patients, young patients. So I think that we have to prove that this treatment is as effective as chemotherapy. And I think that all the cooperative group on CLL are going to design new trials and with chemo-free trials to show that it's possible to use these new compounds and to have the same result as those observed with chemotherapy. We have also to define the duration of the treatment, because for the trial today, the treatment is by oral route, but until progression. And we don't know if we can stop, not stop, how long we have to use this new compound. So I think it's that we are going to show the duration, the combination, the efficacy in the next years.